I'm Ken Goldschneider, Director of the Pain Management Center here at Cincinnati Children's.
And I'm Derek Neilson. I'm a geneticist with a connective tissue clinic at Cincinnati Children's Hospital.
Welcome to our live online chat. And for those of you who are wondering, you should now have sound and picture. And I don't do anything technical, that's as much as I can tell you, but what I can tell you that I do is run the pain management clinic here at the Children's Hospital in Cincinnati. And we have a multidisciplinary clinic. We see kids of all ages right up through college age. And to that extent, we're going to be talking about pain management and related issues with Ehlers-Danlos syndrome, joint hypermobility syndrome. And we're going to be really focusing on pediatrics tonight since that is our strong suit.
And I am the co-director of the Connective Tissue Clinic at Cincinnati Children's. Our clinic sees all different types of connective tissue disorders. By far and away, the most common one that we see is Ehlers-Danlos hypermobility type. And we are involved in the diagnosis and the management of that condition for both children and adults. However, we will be focusing our conversation on children and teenagers today.
And we're delighted to have so many of you with us tonight. We look forward to answering your questions, and we have an hour. So we'll get to as many as we can. We'll answer them briefly so that we can cover as many as possible. And anything we don't get to, we will do our best to answer them all online or with an email that should go out in about a week or so.
Okay, and so feel free to start sending in your questions, and we'll get them queued up and ready to go to answer.
All right. One of the questions that often comes in is kind of a frustration with what this is called and why certain therapies are recommended. So one of the things we often get is, why do physical therapy if certain physical activities hurt? Maybe we ought to talk about that a little bit.
Okay, yeah, I think physical therapy is one of our main modalities of treatment in Ehlers-Danlos. And what we're trying to do is work on multiple different aspects. First of all, there is often an underlying joint instability. That unstable joint tends to lead to extra motion, which causes more stress on the muscles. And this extra stress on the muscles is one of the major sources of pain. Another piece that we often see is a defect in proprioception, which is the ability to know where you are in space and how much weight you're carrying. I like to use an example. If I put my hand behind me, I know exactly where it is because I get a lot of information from my muscles about where that is. That's a sensation that is often impaired and can give a lot of instability to a patient with who also has unstable joints, and that's just a recipe for lots of extra stress on the joints and the muscles.
And really, to combat that, we really use very specific physical therapy techniques. Often regular therapy, people will find that it makes them feel worse. Working on learning where your joints are in space and strengthening the muscles in certain positions to protect them makes a huge difference. And working with the right physical therapist, or one who's willing to learn and become knowledgeable about what to do, is really, really important. Now, Emma asks, what kind of accommodations do you recommend for college students with Ehlers-Danlos type 3? Which is, we're going to use a variety of terms just to pause for a second. Ehlers-Danlos type 3, benign joint hypermobility syndrome, all refer to an overlapping group of things. And so you may hear different people use different things, and we may do that tonight. Accommodations really depend on what the individual needs. Is this a large campus where there's a tremendous amount of walking? Is it something where your dorm room and your classes are close together, where laptops are required, versus can you bring a digital recorder with you so that you don't have to carry books to make notebooks to make notes? So basically, it's assessing your situation and figuring out what's going to make you successful so that you can move from place to place comfortably, so that you can have endurance to get through the day. You may want to look at your schedule and the options for scheduling. One of the things that I would recommend is that since you carry a diagnosis that may need some accommodations and that these may need to be individualized, to get in touch with the Office of, of course I'm blanking, Disabilities. Thank you. And talk with them about the kind of accommodations that are possible and what they can help you with.
I'll just dovetail one point. It's often interesting to find that different colleges handle this differently. And we've often seen that some of the bigger colleges actually are a little bit better at some of these processes, although this is not a hard and fast rule. I think it has to do with the fact that they have a lot more patients or a lot more kids who are coming in with disabilities. And so sometimes they can handle that a little bit better.
Sarah M. writes in, says, and forgive us, you may be able to read this, but just in case people are having any video problems, we're going to read out the questions. Sarah M. says, my child has a lot of pain, but I'm worried about using painkillers and addiction. There are a lot of medicines out there, and how do you know which ones are best for my child? And I think there's a couple of ways to look at this. First of all, I look at medications as being tools to do a job. So if what seems to be going on has an inflammatory or inflammation component to it, then an anti-inflammatory seems to make sense. If you've had a joint dislocation where the joint has popped out and you have this acute pain that's really, it's a hard pain, it's hitting you right then, but it's not going to last for a long time, then a short-acting painkiller such as one of the opioids, like oxycodone or something, may be very useful. Sometimes those dislocations come with muscle spasm as the muscles try to protect the joint after it's been injured, so a muscle relaxant would be useful. Other times we see patients who had repeated injuries and repeated different pains, and it builds up and ends up with generalized and widespread pain, or pain that seems to have a neurologic or neuropathic quality. So medicines targeted at that seem to be real helpful. As far as addiction goes, again, these are tools to use the job. You pick the right one. You use it as part of a bigger program because these medicines don't fix the joints, but they can make life more comfortable and more functional. And we just go carefully and work together as a team. And so if you find things seem to be going in a bad direction, we just need to talk.
So Joseph writes, why does physical therapy make the joint pain worse? Often we hear this story when patients are coming in for the first time that I've tried physical therapy and I just felt worse after having done it and I never want to ever do that again. And the number one reason that that result comes about is really that the physical therapist is not well familiar with Ehlers-Danlos or the approach that is used for it. The approach to Ehlers-Danlos is very different than standard PT. And a lot of times what I'll hear is that a patient will be having pain in their knee, and so what have they been working on in physical therapy? They've been working on the knee and on the knee. EDS physical therapy is very different in that it takes your whole body into account, and it actually has sort of an inside-out approach, so that you have to work on core strengthening and multiple other pieces in sequence. If you do it in the wrong fashion, you are more likely to run into these issues with pain. The other issue that we often see is physical therapists who don't know when, who push too hard, or don't know when they should actually push a little harder. Having good familiarity with the patients is very beneficial. So the first piece that we had to really consider is whether the physical therapist was well familiar with EDS and its treatment.
Heidi's question next refers to her 14-year-old who's a dancer. And here's a sort of a classic problem, because she has pain in her joints and dancing makes it worse. But the dancing helps with her POTS, or positional orthostatic tachycardia syndrome, and her dysautonomia symptoms better. And so, of course, the joints hurt, but exercising helps. The balance is what to do when you have something that you love doing that hurts, but you know you need to stay active because it helps with the dysautonomia. And the answer is to really, one has to look at what are the pros and cons of an activity. We do know that exercise makes a difference with dysautonomia and with POTS. We know that the less active you are, the worse those things get. But it may mean finding an exercise that doesn't stress the joints quite so much. Maybe something in aquatic dancing, water dancing, something where you get support from the joints in the water might be another activity. It's an appraisal where if you can work and strengthen the joints and then get through those activities, then that's fine. But there are going to be certain activities where you have to take a realistic appraisal and say, this just makes me feel miserable, and decide if it's worthwhile or not. And that's a hard discussion, and it's one that you have to sit down and really think about and see where your heart is and see what's worth it to you. Because you're absolutely right, doing those exercises and having a life and having fun is absolutely incredibly important. But deciding where that break point is, where it's overstressing the joints and in the long run not worth it, is a personal decision that a lot of folks really struggle with, and it's a hard decision.
So the next question is, my son has type 6 EDS, so that's very rare. We are currently seeing the neuromuscular team. Are we seeing the right team, or should we be seen by someone else? That's a little bit difficult to answer directly, because it would actually require me knowing a little bit more about what kinds of things you're being seen for and what institution you're at. So those are the kinds of questions we might actually have to answer in a session with you, more directed toward you and your situation.
We have one of the moms asking, do we see pain in the skin that presents like a sensory issue? For example, you can't cut your nails, or even light touch, and those kind of things might hurt because it's very painful. And occupational therapy isn't helping for that. What we see a fair amount is that there's an association with the EDS type 3 and widespread pain. And what we think has gone on is that there have been so many small traumas over one's even short lifetime that the central nervous system undergoes what we call central sensitization, or wind-up. And what that means is that over time, with a repetitive barrage of painful signals, everything starts to become more sensitive. Pain becomes more painful, and after a while, there's crossover at certain levels of the nervous system, so that even non-painful things, or what should be non-painful things, are sensitive. Are painful, sensitive in a painful way. Some of the medications that we use, such as the anti-seizure medicine, some of the old antidepressants, some of the brand new antidepressants, are useful in sort of toning down the nervous system and helping with that kind of pain. Repetitive exposure to normal sensations, what we call desensitization, where you're retraining the nerves, what the proper sensations for each type are supposed to be, is helpful. It's slow, it's frustrating, but it's a real phenomenon, and gets back, actually, in a sense, gets to where Alice is in the UK. Thank you for staying up this late to join us. Is getting at is, how do you make people believe that you have pain? And I don't know that you can force anybody to see the light if they don't want to open their eyes. But I think if you explain your situation, most people will be sympathetic, and you may have to advocate for yourself more than many people do, because you can't see pain, and you can't see what goes on in the joints. You can see that things are bendy, but you can't see how it's being felt. And I think just helping them educate themselves, have them tune into something like this. There's some good resources out there. And I think you'll find that most people are willing to learn, but the first couple times they see something, they may not believe what they're seeing or hearing. But if you stick with it, I think you'll find that they will learn. And what's really hard is when you have those kind of sensory processing problems, which you can't see, they're hard as heck to measure, and they're difficult to understand even for people who do it for a living. It just takes a little while, because they've got to really wrap their heads around some of that, and that's hard. But stick with it. They'll learn.
So the next question from Natalie is, what are the alternatives to Vicodin and opiates for breakthrough pain? Well, obviously, we use medications to try and decrease those breakthroughs, and these can be done in different ways. So there are other medications such as tramadol, which is often a little bit milder than Vicodin and the other opiates. We also can sometimes use medications like muscle relaxers. Now, I have to caution that we do not like to use muscle relaxers in a round-the-clock kind of fashion. But we do like them for breakthrough pain, and we do like them at nighttime. The idea here is that we're still, in trying to stabilize your body, stabilize your joints, we want strong muscles, good muscle tone. If we use muscle relaxers, we're making everything go the wrong direction, and then everything becomes more stable. And we find some of our patients, when they go on these things on a round-the-clock schedule, which a lot of doctors will do, that our patients will find themselves in much greater pain. So I think that would be the first part, and then if it got worse than that, then I would send them over to Ken. So,
and there's nothing inherently evil about those medications. As I said before, they're tools to do a job. So if you have this short pain that's really nasty, and it's not one of these neuropathic type of pains, which really often don't respond well to even the quote-unquote strong medications, they're perfectly reasonable. you use them, and if you find that you seem to be using it more and more, it may be time to get checked again, because maybe something persistent has happened as far as an injury goes, a tear or something internally that is persistently painful that might have happened during that first injury that you were started taking the medicine for. Or could some of the windup be starting to happen where a joint is becoming more and more sensitive and there's this big amplification of pain that can happen, in which case now you're using these medicines and they're not even helping very much, and going up on it isn't going to help. So if you're finding that things are spinning out of control, it's definitely time to grab hold of your doctor and have a conversation about that. Now, Bren asks this great question, which is one of these really, truly classic pediatric questions. Bren asks, my daughter is 5, and what's a good way to teach about pain and how much she's having at the time? Assessment of pain in children, to me, just relies on the fact that children are generally naturally honest. If they're hurting, they'll usually say so. And if they're shy about saying so, they'll usually do something different from their usual routine. In other words, if she loves to skip and play hopscotch, for instance, and she does it a couple of times and then she wants to take a break and do something else, the chances are something either tired her out or is making her uncomfortable. In which case, just asking her, honey, why, you play this all the time, is there anything bothering you that you want to stop? And she may say, oh, I'm bored, I want to go play with a ball. Then pain was probably not the issue. But if she wants to sit down and rest and she points to something and say, kiss it, make it better, it's a boo-boo, or however whatever phrase she uses to say that something doesn't feel right, there probably is pain. Likewise, when is it time to let her go out and play again? At that age, probably when she gets up and goes, because she may lack the vocabulary to give the in-detail descriptions that an adult will do. But on the other hand, kids that age tend to be much more honest and straightforward, and they will just act how they feel.
So Jen asks, will you have any care, treatment, or pain management for adults suffering with Ehlers-Danlos syndrome, hypermobile type? It is really hard to find care and pain management with this disorder. And I agree with you. Yeah. And I guess in our town, in Cincinnati, we have developed a number of resources for adults. Some of those are pain management, some of it is physical therapy, and some of it is a network of other providers who deal with the other issues like the dysautonomia and things like that. I think what this points out is that there are a couple of there is a real lack of understanding of what this is out in the community, and really an underestimate of how prevalent this really is. If you look at the official estimates, they talk about this is about 1 in 5,000 to 1 in 10,000. We see so many more patients than that we really think that this number is more along the lines of 1% of the population. So we're talking about 3 million people in the United States. There is no way that any one center or one doctor in the United States can take care of that many people. So we really have to get this information out and really get the training out there. And so some of the things that we've been trying to incorporate are training programs for physical therapists. And we're really trying to develop more multidisciplinary interactions. But a lot of times, if you don't have those in your own hometown, what you really need as a person, a physician, or any other kind of provider who listens. That is really the most critical piece. Somebody that can listen to you and is willing to say, I don't know the answer, but I'm willing to help you find it. And whether that means they're hitting the books or whether they're calling people on the phone, they're trying to help you establish those. And that's what we actually do a lot of times with the physical therapists when we can't have people coming to long distances to Cincinnati, is we try and help coordinate over those long distances between with physical therapist to physical therapist. And we can do that also with medical doctors as well to some degree. But yeah, so we are trying to develop those resources, but it tells you that in the state of this country and this world, a lot more needs to be done within the medical community as a whole.
And you'll find, I think, a lot of folks out there will be humble enough to say, I've not heard of this, but I'll look it up. And I can tell you just from personal experience, this is not something I learned about in medical school, and that was 20 years ago. Then in the 90s, I was reading articles that were saying joint hypermobility is really not a cause of pain. And that's what we were learning. So it took a while, even for those of us who do this all the time now, to unlearn some of the mistakes that have been made in the past and then to really gain enough experience to go forward and to finally be helpful to anybody. So I think you'll find a lot of people are like that, and that they're willing to call each other, call us, call whoever they need, look things up. And with all the electronic resources now, they can do it faster than they used to, and I think that's going to help. One of the questions that's come up is my daughter has muscular trigger points that cause her pain. And do we have any advice on how to handle these clusters of muscle tightness? Trigger points, which lead to myofascial pain, are one of the most common forms of pain that we see in our pain clinic. It's one of the most common forms. And for those even without the EDS, they're really common low back up here in the upper back and the neck. A lot of times for our electronic passions where we're holding our shoulders up tight, working on the computer and so on. Massage can be helpful, a stretching routine, good ergonomics. And a lot of EDS pain control is good ergonomics. Are you listening to your mother? Are you sitting up straight? Do you have pads under your wrists when you type? Things like that, that if you can take the pressure and the strain off the muscles which are trying to hold you from an improper position, that will help. Sometimes we'll do what's called trigger point injections. They can work really nicely, but being injected is not everyone's favorite thing to have done. But that involves putting a very thin needle and injecting a little bit of local anesthetic into the trigger point, which helps relax it and break it up a bit. Sometimes having it massaged out with some deep tissue massage. You do have to be careful so that you're not applying a lot of traction or pressure over a joint. But, and again, sometimes a mild muscle relaxant to help that process. And our psychologists do a really good job with something called biofeedback-assisted muscle relaxation, where they put sensors over the affected muscles and show how tight they are by the electrical activity on the computer screen. And you learn some relaxation exercises, and you can bring down the tension in the muscle. And a combination of all those things can be really, really helpful.
Okay, the next question is, what are the standard tests that should be done once you have a clinical diagnosis of EDS hypermobility? So that can be broken into two parts. One would be diagnostic testing, and the other one would be a monitoring kind of testing. And the first part to know is that there is no genetic test that we use to confirm the diagnosis of Ehlers-Danlos, at least for the hypermobile type. It is purely a clinical diagnosis, and you do not need to have a skin biopsy or molecular testing for that. The next part would be, are there any standard recommendations? So it used to be that we would tell everybody that they needed to have an echocardiogram because there was a risk of having a dilated aortic root. And that was a study that was actually done here, and then the follow-up studies that were also done here showed that, you know what, those kids that had the dilated aortic root, it tended to just normalize over time and didn't really cause much of a problem. So we've actually gone away from that unless there has been a family history of an aortic problem, or if we're getting other kind of issues that might cause a concern for a cardiac condition, including chest pain and things like that. So we don't do this as a standard anymore. Although you may find that in other institutions they will tell you you have to have an echocardiogram, and and there are some places that will always do collagen 3A1 testing for you, and we usually do that on a as needed kind of basis. And then the other tests that we commonly do might include, evaluations for dysautonomia, for CNS malformations and those kind of things, and we really do those on a as-needed basis depending on what kinds of history and physical exam findings we have.
Now, one of the questions that we're getting now is about sleep. Sleep is a big deal. Sleep is a big deal for anybody who has pain, and it's particularly a problem with EDS. The question has to do with a teenager who only gets a few hours of sleep a night, and it's a combination of pain and insomnia. And the answer is, what can help? And the answer really focuses on, depends on what the problem is. Certainly working on the pain, and whether that's combination of medication, working with psychology for coping and the muscle relaxation and such I was talking about, pacing, making sure that you're getting some aerobic activity during the day but not right before bedtime. Things like that can all help build up a good sort of need for sleep. If you haven't been doing anything all day, you're not going to be tired at night. And that's not the case for most folks, but it can be an issue. Avoiding caffeine, having a regular bedtime, and having a regular getting up time. making sure that you're not watching videos or playing video games right before you go to bed, because that strong light affects some what we call nuclei, or little clusters of cells behind your eyes, which help wake you up. Because that's what helps wake you up in the morning, is when the light shines in your eyes and suddenly your hormones are flowing, you wake up, so you don't want to stimulate those right before you go to bed. There are also issues with EDS with obstructive sleep apnea. So if they're snoring or snorting or having pauses in their breathing, they may need to be evaluated in a sleep lab to see what is the cause of the problem. And then, of course, you then tackle it if there's something more specific than the general things that I just said.
Okay. And our next question is there information that can be shared with emergency room doctors for treatment, as they are not informed appropriately? Well, it gets back to my point that we really do need to get a better education throughout the medical community about this condition. But, you know, as a clinician who often cares for children with very rare disorders, for those that we expect that there will be complications, we often can provide an emergency letter that details the diagnosis and what are the common complications and things that we would need to be worried about. So this might vary depending on what kind of EDS type we're talking about. So obviously we'd have a very different letter if we're talking about vascular type than the hypermobile type. And the other part is that we might need to make it a little bit more specific depending on what kinds of things we might be expecting. So if you have lots of episodes of fainting and things like this that are related to potentially dysautonomia, we might need to tailor that letter to that specific problem rather than just say this patient has Ehlers-Danlos syndrome, because if I tell them that, they probably won't know much about it. So you have to be a lot more specific, I think, in these letters and information that we share. On the flip side, we don't want to overload an emergency room doctor with a volume of charts or papers this large, because they've got a very limited amount of time. We've got to keep it very brief and short, and really to highlight the most important dangerous pieces to look for.
Now, next question that comes up is another sleep-related question that has to do with growing pains at night. Growing pains are, and of course they wake up and they're crying and their legs hurt, and usually by morning they feel better. It's usually worse if they've been active during the day. But of course that sounds a lot like what goes on with EDS too. So I'm a little careful to call something growing pains if I know a patient has Ehlers-Danlos. And I'd want to make sure that, are we doing things with the proper shoe inserts, with good physical therapy? Are they doing an activity that is really overstretching their joints? And then they pay for it at night. And then of course if you don't sleep, you don't get restorative sleep, your muscles don't relax, your nervous system doesn't get a chance to reset itself, you wake up and you're miserable the next day. But those are some of the things I would do, is really be careful and see what's going on during the previous day that might be setting up nighttime pain, and see what there is to find there before I would call this just growing pains. If it's growing pains, of course, it's going to get better. If it's EDS, then it's something that's going to take a change in lifestyle for the long term.
So the next is, why do doctors recommend psychologic therapy to help with pain when it is a joint condition? And this is a very good question, one that we get asked a lot. And I think I could answer it the other way, is to say, why wouldn't we do this? I mean, what we see is when a person is having a lot of pain, it changes things in your life. And we see that these, self-perpetuating cycles begin to break in. And we see patients begin to give up things that they wanted to do. And as each time you give something up, you begin to feel bad about it. And that emotional state changes your perception of pain. Pain, we were talking about this concept that pain is an experience. It's not something that lives here, and it's not just all in your head. It's an interaction of all these different nerves. And so this experience can be altered by your emotional state, by things going on around you. And when you start giving things up, this changes the emotional state. You begin to perceive more pain, and then that means there's one more thing that you can't go to the next thing the next day. It might be the dance or the football game or whatever. And as that progresses, a person really becomes more restricted in their world, and all their friends that they used to hang out with are sort of going away because you cannot keep up with them, those kinds of things. And so a patient really needs to break that cycle, and it's really something that they cannot do alone. And so that's one of the things that psychologists, and it's really cognitive behavioral therapy, is really trying to give them the tools to recognize what is happening and to break through that cycle. And sometimes it has to do with, how do you get out of bed in the morning when you just don't feel like doing it? Trying to give you those tools and concepts to help you break through those barriers.
And that is a wicked important concept. This is a skill building set. This is not sitting on the couch talking about how your kitty cat passed away when you were 3 years old and you've been traumatized since. This is, what do you do to have a life? What do you do to deal with the burden that the pain has put on you? And I defy anybody with chronic pain to say it's not a burden, because it is. It stinks, and it goes everywhere with you, and it can affect every part of your life. And we're not hurting body parts, we're whole people. So we firmly believe that we should treat the whole person, and psychology is really important because that's part of being a human being.
So the next question is actually, I guess the next question is yours, isn't it? That's all. Okay.
Well, the question is, how do you find a doctor to give a 14-year-old pain medication since they're so strict with it now? And also, will this progress? And I assume that we're talking about the pain or the EDS in general. And I think maybe we can split this one. Medications will be available more or less readily, depending by state, country, because that affects what the local laws are, what the local practice customs are, and even availability. Because I visited enough countries that they certainly don't have some of the medicines we have here. And on the other hand, they sometimes have medicines before they get through the FDA, and we ever see them, say, 10 years later here in the United States. So some of it depends on that. Some of it is just building a good relationship and having an understanding with your physician. Most physicians care enough that they want to do something good for you or for your child. They may or may not be experienced with the particular medication that might be the right tool for the job. But that's why they have consultants. That's why they have colleagues that they can call for advice. And I think if you have somebody who's not listening to you, then you could consider looking for another physician. If you have someone who's listening to you and willing to work with you, I think you'll find that they may go slow, but they'll go steadily with you, and you may have to walk on this journey together. Remember, just because we see several hundred people with EDS per year doesn't mean they see more than 1 or 2 that have serious problems, and they're still learning the way we had to do way back when we were starting our careers. So basically, you don't want to beg, you don't want to threaten. Just be straightforward and ask, what's the best medicine for the kind of pain that's going on right now? And see what their recommendations are. And just give them feedback that, hey, if you're not comfortable, we're willing to work with you, because otherwise you've been a great doctor and we like working with you. But can we look into this together and get some more expertise on this and help them feel more comfortable? And we're certainly happy to be resources for folks. We work with doctors from good distances by both phone and email. And you'll find that there are other centers too who are happy to say, hey, you know what, electronic media makes it easy. Let's be a resource, and they can work with us, and that may give you the help that you need. And as far as progression, what to expect at age 14?
So at age 14, that's, so the question was, will this progress? And I think there's 2 ways of answering. One is if we don't do anything, there's a good possibility that it will. However, if we give the correct interventions, we may be able to stop that progression or lessen it to some degree. It's hard to say with every patient. What we do see is, the younger kids tend not to have so much pain. Once puberty comes in, we see a lot of these things really flare up at that time. So a lot of the headaches, a lot of the chronic pain, a lot of the dysautonomic symptoms really flare up around that time. And so as kids progress through adolescence, there is really that potential that things can get worse, and that's where we really have to work with them to really build up that muscle tone and really protect those joints and really get on top of as many aspects as we can, including the regularity and scheduling of their life. And I know most people kind of associate schedule with being a bad thing, but that's actually having a regular schedule, regular sleep time, a regular exercise time. All those things are very important and helpful. It's also a good thing to incorporate, because once a patient goes off to college, that's probably the first thing to go. So but getting back to the progression, we have seen people get worse, and then I've also seen some people who got worse get much better. And this is always really impressive. I have seen people who were keeping wheelchairs at school because they just needed them by the end of the day. And then a couple of years later, after lots of work, they're running 2 miles a day. And sometimes you just think, I never expected to see that, but it can be done. How much did I personally contribute to that progression? Well, we gave them the guidance, but it was the patient themselves who really took control of that and really was responsible for their own improvement. And that is just phenomenal about this condition. It can be done.
Absolutely. Question about a 5-year-old who's still using the stroller and a cart at the store and just can't handle doesn't have a lot of stamina, can't handle a lot of walking. And the question that their doctor wonders is if he just needs more exercise. And while I can't say whether he does or he doesn't, because I don't know what he or she does, but we would want to look at some of the mechanics of their walking. Would you evaluate for flat feet and see whether an insert at that age would help?
This is one of the stories that our physical therapists like to talk about a lot, is that it's amazing what a simple shoe insert can do. And so they talk about the child who can walk from one end of Walmart to the other, and then they're done. And then when they go into physical therapy, they give them shoe inserts that keep their foot from collapsing every time. Because what happens, if your arch collapses as you walk, you have a tendency to roll your knee. And as your knee is rolling, you're getting a lot of this side-to-side motion, and that's where a lot of the pain and fatigue is coming from. If you can get that rolling motion under control, you can actually go a lot farther. And then exercise just comes about on its own at that point. And 5 years old, it's sort of that 4 to 5 year old age point is one of the times where we see that really the most. So so physical therapy, I would say, would be the correct place to go, not necessarily to have more exercise. Now, there are some patients that may actually have more low tone, who may benefit from more muscle building kind of physical therapy. And I think that's something that you really kind of have to build a plan with that therapist when you begin working with them. There was a previous question that also related to should a preschooler who's not having symptoms be given physical therapy in a preventative sense? And that we kind of decide on a case-by-case basis. The critical times that I think for doing physical therapy in a preventative mode are really around 8 and 9. If you haven't had any by then, that's really when we should probably start, because puberty is really right around the corner, and that's when we see a lot of the acceleration of symptoms. But the preschoolers who are not having a whole lot of problems, we tend to let them go until we begin to see either some of those growing pains begin to creep in, or they just get old enough where it's time to go ahead and do that. But some of that also has to do with an assessment of what's their muscle tone like and what is their gait like. And sometimes we might send them as they're a little bit older, just the PT, the therapist, knowing that they may not actually do very much, but just to get an assessment of, are we actually running into any kind of problem areas right now.
Well, I think we've been seeing a lot more names showing up on the list here, and I just want to welcome anybody who's joined us in the last little while. I'm Ken Goldschneider. This is Derek Neilson for Cincinnati Children's Hospital, and as you've probably already figured out, we're talking about pain management in children and young adults with Ehlers-Danlos syndrome. And we've been taking questions, and our next one says, we have really struggled with our 9-year-old's behavior. Living in chronic pain can make kids cranky. I'm with you on that. What kind of other supports can you recommend for kids living in chronic pain? Well, we talked a little while ago about psychological interventions, and some of the coping skills, distractions, and so on are age dependent. 9-year-old is a little young to do some of the more advanced things that they do, but some of the 9-year-olds respond very well to distractions, whether it's learning calming techniques like blowing bubbles as opposed to doing something more sophisticated like yoga. They can be given ways to just express themselves. Do they want to play, if they play an instrument, or do they want to just go bang on pots and pans in the basement? Are there things that they want to get their frustrations and irritability out on other than yelling at you? The other, of course, is to just let them know that you're there for them, and You don't want to overindulge them. You don't want to ask them every 2 seconds how their pain is, because that just reinforces that they have a problem. And that's something we actually advise staying away from, is not checking with your kid about their pain all the time. But just to let them know if they're not feeling well, that you understand, and if they need to take a break, that's cool. They can take a break. If they really can't walk to the back of the store, so they hate going shopping with you and they fuss at you every time, then maybe, as Dr. Neilson was saying, we should look and see whether they need inserts or something to make that a more comfortable experience for them. Now, of course, 9-year-olds can be cranky for lots of reasons. They're starting to get into the school years, and there's all sorts of pressures and stresses, and stuff that even we remember from long ago was like, well, yeah, it made me cranky too, even if I felt well. So we don't want to ignore the normal things that go on in kids' lives that can make them stressed and upset. Now, besides psychology, there are just different hobbies. Sometimes kids do really well if it's in the family, wherewithal to have a pet, so that they can have something to kind of just spend a little relaxing time with. Like I said, other kids respond well to music or gentle physical activities or reading books or something, or just having time to themselves, where they get little breaks during the day so that they can just kind of recover a little bit and not feel constantly like they have to keep moving, which they'll then fight back against.
So the next question is about complementary techniques. And so it reads, I read that acupuncture can actually stretch the collagen with the needle. Is it safe? And what about massage or chiropractic? So all these techniques have been used in our patients, and we have not seen any untoward effects on the collagen from acupuncture or anything like that. So we're perfectly happy with acupuncture. I also like massage therapy, not for personal reasons, but because it is actually stretching the muscles out, which is what you really want to do, rather than trying to stretch the collagen, which is what you do when you're trying to stretch your arm out or something like that. It's stretching the whole unit. So that the massage therapy can actually relax things a little bit in a better way, I think. As far as chiropractic, that's a kind of a mixed bag answer. And it depends on how familiar, I know I keep coming back to this, but how familiar the practitioner is with EDS. Manipulation of the back is generally okay as long as they're not over-rotating, because we really want them to keep within physiologic means. We try to stay away from the neck. That's one of the areas where I tend to see more patients coming in with complications. One patient was telling me that every time they had their neck manipulated, they would have a headache for 3 days after that. And all you can say to that is, don't do that. Right. But we have had good successes with some of our chiropractors who have actually been very encouraged to look up more information about EDS and learned a lot about it. And in fact, have been some of our resources in other cities when we didn't have physical therapists who were trained. They were actually learning about the physical therapy techniques and working through these processes with our patients. So we have had some good interactions with chiropractors in the past.
A question about whether to take anti-inflammatory, the non-steroidal anti-inflammatory medications in somebody who has reflux and GI bleeds, and then whether or not it might be appropriate for their child to take the medications. A couple things on that without knowing circumstances, because there can be other reasons besides the medications for having the reflux and the bleeds, but certainly we know that they can make those things worse. One is things like celecoxib, and medications similar to that, of which they may vary from country to country, but that's the one basically in the United States, that are not really all that bad on the stomach. And for someone with bleeding problems or with reflux, they can be useful. As far as what to do for your child, I would not assume that because it bothered you that it's going to bother them. They're a little earlier in life. Now, obviously, I don't know their genetic makeup, and I haven't done an exam or seen what other risk factors they may have, so I can't comment further. Got it. But it's probably fine to use in modest doses, and some of the celecoxib and things like that can be used in kids of a certain age, again, by providers who are used to prescribing those medications for kids, because they're not used all that commonly. So I just want to address one thing. I know, Abby, you wrote in a really good and detailed question, but it's of a nature where we'd really have to have more of an online conversation, and in fact probably either see you or talk with your physician or something. It's fairly complex and specific, and we can't get into that kind of clinical detail here. It wouldn't be appropriate to you, your child, or everybody else. But thank you for writing in. We'd be happy to figure out some way to talk with you at a later time about that specific question.
So
The
next
last
question,
one's a good one.
what are the correct interventions that will facilitate the slowing of the progression of hypermobile type EDS? So this gets back to one of the things that we mentioned earlier, which is that the protective factors for EDS are often the things that that seem to be the opposite of what you would think or that you want to do. So when a person is having muscle pain, it's one of the most difficult things to say, what we need to do is build your muscles. Well, those are the things that hurt, so I don't really want to use them. So we have to kind of go about this in the correct way. And so physical therapy is one of the most protective factors and interventions that we can use to slow or reverse the progression of hypermobile type EDS. And again, it's about toning the muscles, stabilizing the joints as best we can, because when we've got loose collagen, all those ligaments and tendons, they move too much. And we can't do anything to make them shorter. We can't make them tighter with any medications. So we work on the muscles, because the muscles, we can actually improve the tension here and provide more tension across that joint, pulling it closer together. That's really the goal of that strengthening process. And then the other aspects really have to do with the balance and proprioceptive defects, and trying to stabilize the core so that as your joints may be wobbly below, that your body isn't contributing to this with excess motion and balance. The other pieces are really the lifestyle changes that we need to take into account, which have to do with how do you respond to pain. And for that, we use the cognitive behavioral therapy. And we also work with that for developing the life management skills, trying to make sure that we pace ourselves correctly, that we're not, we see a lot of our patients who are running, charging along in life, and then you go off the cliff, and then you're in pain for the next 2 days, and then you get enough energy to do it again. And what we have to do is kind of turn those cliffs into rolling hills. Everybody's going to have their ups and downs, but we have to try and figure out how to modulate this a little better. So those are some of the aspects that we work on, although that certainly a comprehensive list might take a little bit longer to complete.
Well, in fact, our next question asks a bit about some of the lifestyle changes in terms of asking about what is a good low-impact exercise, because a lot of the activities hurt. And I'll echo what Dr. Neilson said about the ups and downs of overdoing it. The problem with kids, of course, is that they're still learning to give structure to their lives, to their day, and to pace themselves. I can tell you when I was 16, I was all go and no slow until I would crash at the end of the day. It's not an unusual way for kids to be. The problem is that when doing that causes a lot of pain, it's not the best way to go about doing it, and it just takes a long time to kind of get that balanced out. And heck, it's hard for some adults to sort of smooth that out from cliffs to hills, as Dr. Neilson was saying. But getting in the water, where the water can support your joints, where you're moving against resistance in a very gentle way, you're not overstretching your joints in doing so. Certain say Tai Chi, certain martial arts, but Tai Chi is a good one, where you can be in motion. It's not fast, it's not aggressive. It's still a martial art, and I have studied it a bit and learned what some of those motions really mean as far as doing joint locks and takedowns and stuff like that. So it's really in there as far as having that combat, but it's slowed down to a pace that you can focus on where your joints are in space. You can focus on your posture. You get really good mental focus. And I keep saying that word because the more you've got your mind on pain, the more pain is your world. The more you can push it to the background and focus on something else, you do what I call creating selective hearing for pain. So we all know what selective hearing is, right? You're doing whatever you're doing, and you get called 5 times to come to dinner or to mow the lawn or do your homework or whatever it is, and it's not until someone's in your face that you notice. Well, your ears work just fine, right? It's the old question, are you deaf? It's like, no, Ma, I heard you. But it's because your brain processes things in a certain way. And what's in front of it and gets your full attention gets processed the most, and everything else gets filtered out. So by doing something like Tai Chi or some of the other slower, very deliberate exercises, you mentally can put some of the pain out. Not that your joints aren't doing some unpleasant things at times, but it's not making you suffer in the same way. And sometimes doing those exercises can end up being more rewarding as you build up stamina.
So the next question is Kyary and EDS connection. This one's a little bit difficult, and I think what we often discuss in the clinic is that this is sort of a controversial topic. We have a lot of patients, and some of them have Kyary malformations. Some of those patients have had those Kyary malformations when they were born. And for many of those patients, and I should say what a Kyary malformation is, it's a protrusion of the cerebellar tonsils down below the level of the skull, so everything's kind of packed in there, and the idea is that it can cause compression of the brainstem. So the idea is some of our patients can actually have that, be born with that. Many of them are actually unaware of it for many, many years. And then they may actually have some symptoms that actually go along with many of our patients who have EDS. And then they get a neuroimaging study, and that's when it's found. And then the connection there is, was your symptoms because this was what we normally see with EDS? Or was this actually due to the Kyary? And sometimes those can be difficult to separate. But the number of patients that in the childhood years who actually have to go to any kind of surgical correction tend to be on the lower side. Now, on the adult side, it's a little bit different, and has to do with degenerative changes of the spine that could potentially cause traction on the brain, on the spinal cord, and hence the brainstem. And that's kind of a different issue. And since we're limiting our discussion to children, I won't go into it any further than that.
Shall we go to the other end of the body? Do you have what do you think about what happens when someone's tried a lot of foot supports and just nothing works and they keep rolling their feet in no matter what, or it's uncomfortable?
Yeah, I've seen that one up there. I've been delaying on answering it, trying to decide how to.
We are two honest souls. We're not going to. We don't claim to have all the answers.
It's hard to know exactly what you've been through, so it's hard to answer that directly. So some of the harder braces can be irritating. Now, that's not those AFOs, those high braces. We usually don't use those. So usually it's actually the shoe inserts, and that's usually enough. But if those things have all been tried and you're not tolerating them, then it becomes an issue of, is there an actual anatomic problem that's different that would actually need to be evaluated by an orthopedist? That's one possibility. The other, if it's just that it's really collapsing and we just can't get it to stand up. Sometimes other things such as wrapping the foot, I've seen some patients actually have some success with that. But it gets a little bit more difficult to answer that directly without seeing what the feet look like and what you've tried in the past.
And as far as what kind of orthopedic surgeon to see, there was a question that came up about they have a 13-year-old and they have boat-sized feet, as many 13-year-old guys do. I would say at that age, they are still growing, they're still developing. They will have some specific pediatric issues. They may be adult size, but they're not adult in development yet. And my recommendation would be to see a pediatric orthopedic surgeon if at all possible.
So the next, shall I take that next?
Sure.
My teen daughter's menstrual cycle worsens pain and subluxations. How can we manage this? This is one of those things I think a lot of physicians probably don't understand, but we do see this complaint quite a lot. Not everybody has it, but many notice that at certain times of the cycle, everything just gets worse. And in these cases, it may be advisable to try and work with an obstetrician or a gynecologist to actually regulate those cycles. We have seen some success with some of the oral contraceptives in sort of decreasing some of those large hormonal shifts, and I think that has had some success in reducing those flares that are basically menstrual associated. There are some formulations that will actually, last for months so that there aren't any menstrual fluctuations during that period of time. And we have seen some limited successes with that. I can't say that everybody who has done that has had success, but we have seen some.
Now, here's one that comes up a lot, and this is a sore point, literally but mostly figuratively, and that's what kind of sporting activities are okay. The question is, should I keep my kid out of contact sport? And I would say, by and large, the answer is yes, for most purposes. But it depends on what you call contact. I would think football would be a particularly bad idea.
My only absolute answer to that one is football, mostly because I see a lot of patients on the other end of the spectrum where they're in their 20s and 30s and they've been on their 5th shoulder surgery, and you go back to where it was the first time you dislocated your shoulder. Oh, it was playing football. And that the risk for dislocations is high enough that that's where we are really saying we should limit those kind of contact sports. Now, there are a lot of other sports where there is relative contact. Some of it is going to be intentional. So with football, you're supposed to tackle somebody and make contact. With other sports, such as soccer, it might be more incidental contact. Basketball might be more a contact under the basket, that kind of thing. So it's not a hard and fast rule because it depends on at what level of intensity you're playing. If you tell me that your 11-year-old wants to play soccer, I'll probably say okay. If it's your 18-year-old who wants to play football and has never played organized sports before, absolutely no. If it's something like they're trying to work on playing with a really competitive team, you really have to kind of gauge how well your child is doing in that sport already. If they've had a lot of injuries already, I might be a little reluctant to say that's okay. But on the flip side, we want our kids to be active. We don't want to be taking them out of sports. We just want to find the things that are right for them. So, we love things like swimming. It's low, it's no contact. It has reduced strain on many of the joints, although some of the physical characteristics of certain patients mean that they can do some of the strokes, but not all of them. But I would say my only hard and fast rule would be football is bad for the shoulders. Anything else, you really have to gauge what level of activity. Rec league sports, probably okay. Varsity sports, maybe not, depending on what you're doing.
Now, there's a question on one of the more gentler activities, and that's yoga for EDS. And can you overstretch without knowing? And that's a great question. That gets back to what we talked about with the proprioception, or feeling where your joints are in space. Yoga can be really, really good. A lot of people with chronic pain use yoga because of that mind-body focus connection that I was talking about before. The issue becomes some yoga is really an extreme in the positions that they take. And to be honest, from what I've heard, that's more an American thing. There are a number of different ways of doing yoga, and I would advise anybody who wants to do yoga to sit in on a couple of classes. Just watch, talk with the teacher, see what philosophy they take. There are going to be a lot of yogas that you'll be able to do very successfully that will not put your joints at risk, and you may just enjoy the heck out of it. Otherwise, you just have to go slow. When you try a new position, see how it feels. If you feel anything that leaves you achy afterwards, think twice about doing it again, because again, if it's that gentle and it makes you achy, then you probably don't want to do it repeatedly.
And so the next question is, any holistic therapies or herbs and vitamins, are any of these recommended? This is always a tricky one because there really aren't any studies that support that any of these things would actually work. And so when you're trying to make recommendations, you want to have some kind of background that says, here's how many people will respond to this, here's what kind of therapeutic effect you should expect, here's what kind of dosing regimen you should use, and here's when you go up, and here's when you go back. And those things don't really exist for these, and you just don't know if any of them work. On the flip side, the things like vitamin C and vitamin D and magnesium, you can get over the counter, and they're within your control. The only thing that is, and a lot of people in the EDS community are talking about magnesium these days, and that one is just hard to know exactly what to do with because the studies aren't there that really support it. And the flip side of magnesium is that it can actually cause diarrhea. Now, some people might actually find that to be a therapeutic benefit if you've got constipation, but for those who are more on the hyperactive bowel side, that may not be a great idea. So We don't have any standard recommendations for this, primarily because no one's really done the studies that show that they will work for this population of patients.
And the only thing I'm going to add is with the herbs and related things that if it can have an effect, it can have a side effect, and it can have an interaction. It means there's something in the herb that if it's helpful, that's great, but it can, like I said, have side effects or interactions with standard pharmaceuticals. So you just have to treat them like medications, and just because they're labeled as natural doesn't mean that they're safe. Now, for our last question tonight, we've got a multiple question, and this is a logistics question that a lot of people just find completely frustrating, and we're very sympathetic with. And that's, how do you find a specialist in your neck of the woods? The person describes that their child has seen a lot of orthopedic surgeons, primary docs, cardiologists, and no one seems to know how to help. Well, in some ways, that's what we're here for. If you have a good relationship with your primary care doc, we would be delighted to talk with them. They're going to know sort of what the lay of the land is in your area. We can kind of tell them the kinds of things to look for. And again, we don't mind doing a little hand-holding while they come up the learning curve on how to help with EDS. So if a couple of phone calls or a couple of email exchanges, and maybe we send them some literature, will help so that you now have homegrown your expert, that would be perfectly fine. If it's something that requires truly specialized care, surgery, or a testing intervention that's not even available locally, then we'd be happy to help with a referral.
So I'd like to thank everyone for joining us this evening. It's been a pleasure answering your questions.
And we just want to let everyone know that your questions were awesome. It's obviously a very thoughtful group of people, and we just could not get through all the questions. So we apologize for that, but we will do our best to answer them over the next week, and we'll try to send them out by email. Please don't be insulted if we don't answer your specific question, because there were several themes, and we will try to answer them as broadly we can, so that, just for practical purposes, to be honest, but we will try and get you decent information as best as we can. Thank you again so much for joining us. It's been a pleasure spending the time with you. I'm Ken Goldschneider, and good night.
And I'm Derek Neilson. Good night.